Good afternoon, everyone. My name is Hannah Clem. I am a senior psychology student here at Sam Houston and an undergraduate research assistant in Dr. White's psychopharmacology lab. Our lab focuses on the development, validation, and utilization of the avian model of anxiety and depression. My presentation today focuses on the evaluation of pre and probiotics for antidepressant effects in an avian model of treatment resistant depression. I would like to take this time before beginning to thank Roanna Debler for the use of her McNair research project and Dr. Stephen White for his guidance and mentorship in developing this presentation. Major depressive disorder, or MDD, is currently the leading cause of disability worldwide. It has not only personal ramifications, but fiscal and societal effects as well. Odds are you know someone in your life or you yourself have suffered from depression at one point or another. What some may not be aware of is that finding treatment for depression that works consistently and on a long term basis is quite difficult. And for a portion of people living with major depressive disorder, there are also those that deal with treatment resistant depression. Treatment resistant depression, or TRD, refers to individuals that do not respond to two or more traditional antidepressant prescription regimens. The prevalence of treatment resistant depression and lack of relief for patients has led researchers to question our current monoamine theory of depression, which relies on the idea that depression is caused by a deficiency in the neurotransmitters serotonin and norepinephrine. Those who suffer from treatment resistant depression receive little to no relief from popularly prescribed SSRIs and SNRIs. Treatment resistant depression patients are at a higher risk for suicide than traditional MDD patients, which is one of the driving forces behind finding effective treatment options for these individuals. Recent research has led to the link between the gut brain axis and depression. Research suggests that a gut microbiome with excess unhealthy bacteria can contribute to what is referred to as gut dysbiosis, and it puts individuals at an increased risk for stress and a variety of mental disorders. There is a correlation between gastrointestinal related illnesses and mood disorders. Many patients with irritable bowel syndrome, a common large intestine related illness, suffer from psychiatric comorbidities. Those who have irritable bowel syndrome have a less stable and diverse gut microbiome in comparison to individuals with no gastrointestinal illnesses. Their gut microbiome is also very similar to those that suffer from major depressive disorder. Researchers theorize that modulating the gut microbiome via pre and probiotics might yield antidepressant effects. Probi- or Prebiotics are specifically selected fermented ingredients that can result in changes to the composition and activity of gastrointestinal microbiota. Prebiotics work to help increase the longevity of probiotics and feed healthy bacteria in the gut. Probiotics are healthy, beneficial bacteria that we consume through food or supplements. Promoting a healthy gut microbiome might reduce or prevent depressive symptoms. Pre and probiotics are currently the most popular method for introducing healthy bacteria into an individual's gut microbiome. The aim of this study was to evaluate the efficacy of pre and probiotics in the stress vulnerable, treatment resistant Black Australorp genetic line to see if they produced any antidepressant effects. Our lab utilizes the avian model of depression and anxiety. This unique model relies on the knowledge that chicks are social creatures and will vocalize their distress if separated from fellow chicks. In this model, the behavior of the chicks occurs within two phases, what we refer to as the anxiety phase and then the depression phase. At the beginning of isolation, chicks will vocalize loudly and often, but after a period of time, their vocalizations will either halt altogether or become extremely intermittent, indicating behavioral despair and their entrance into the depression phase. The rate in which chicks enter into onset of behavioral despair is how our lab measures the stress resiliency or vulnerability of a particular chick strain. This study utilizes the stress vulnerable strain of Black Australorp chicks, who possess a shorter latency to enter behavioral despair when compared to the onset times of other strains. Like those that suffer from treatment resistant depression, this strain is also non responsive to two FDA approved antidepressants, the SSRI fluoxetine and the tricyclic antidepressant imipramine. The black australorps help us to simulate the behavior seen in humans with treatment-resistant depression. This brings us to, to our hypotheses brought forth by researchers. As the study is exploratory in nature, we had two hypotheses. The first was that the pre and probiotic group would display significantly higher distress vocalization rates in the depression like phase compared to the control group, indicative of an antidepressant effect. The second was that the pre and probiotic group would show longer latency to enter behavioral despair, indicative of stress resilience. This study utilized a variety of methods to test researchers' hypotheses, beginning with subjects and housing. Male black Australorp chicks were acquired on their hatch day and placed into stainless steel housing units with 12 chicks per individual cage. Chicks were free-fed food and water via gravity devices within their individual home cages and were kept at a species comfortable temperature of 30 degrees Celsius. Continuing with our methods, we have the isolation stressor apparatus pictured here, consisting of 6 moderately sized individual plexiglass units, each containing a light and microphone to record distress vocalizations and to observe behavior of subjects. Lastly, in the methods, we have our procedures utilized during the experiment. Over a period of 7 days, chicks were housed in the housing apparatus and divided into control and treatment groups. During that time, the control group were administered untreated feed and water. The treatment group were administered feed and water treated with both pre and probiotics. On day 7, the chicks were divided into squads and introduced to the isolation stressor apparatus. They were in isolation for a period of 90 minutes each to record devokes and then placed back into their home cages. That leads us into the results portion of our presentation. This graph, labeled as Figure 1, shows the mean distress vocalizations as a function of time in 5-minute intervals. The control group is represented by the blue line, and the probiotic group is represented by the orange line. As shown in the graph, in our anxiety phase occurring within the first 10 minutes, we see high devoke rates. As the chicks approach their threshold for entrance into behavioral despair, we see devokes decrease and level out around the 20-minute mark. A one-way ANOVA failed to reveal a significant effect for treatment. However, the findings did trend towards significance with a p-value of 0.069. This graph, labeled here as Figure 2, is the mean latency time as a function of depression onset thresholds in percentages. The blue line represents the control group, and the orange line represents the probiotic group. A multivariate ANOVA failed to reveal any significant group differences for latencies to enter behavioral despair. Lastly, our discussion and future research. Administration of pre and probiotics failed to produce antidepressant effects and failed to provide resiliency to the isolation stressor. In comparison to rodent models investigating the role of the microbiome, they administer pre and probiotics for up to 3 weeks prior to testing. In the future, we would like to extend the administration of pre and probiotics from 7 days to 14 days to determine if this will yield more statistically significant results. Thank you for your time in viewing my presentation. If you have any questions, you can email me or my faculty advisor, Dr. White. Our contact information is listed here.